After 37 years at Columbia, I came over to NYU Langone Medical Center. Every 37 years, like clockwork, I switched institutions to create a program to help make more empathetic and sensitive doctors. Not that we need them, but that's where I am right now. I see clinical patients in the morning, internal medicine and GI, and then in the afternoon I go over to CBS, and I'm there until 7 o'clock. This is an astounding collection of people. When you walk into the main hall and you see Risa Sperling and Rudy Tanzi and David Margulies, you know you are in the right place. And my dad is 96 years old. He's still in great health. He lives right next door to me. He was in the Battle of the Bulge. He landed at Normandy. He was in Patton's 3rd Army, 193rd Division. He's told me all about it. There was less planning for the invasion of Normandy than there was for this conference. I'm telling you. It's very, very impressive. And I'm glad because I've done a few of these panels now, and the new word is disruptive, right? Disruptive technology. I'm so happy that the word disruptive is now a positive, because when I was in 6th grade, and I could have been spared so much aggravation from my parents. Anyway, I'm going to introduce our panel. First, Dr. Antonio Chiocca and Dr. Merit Sikovich and Dr. Scott Roush, who are going to each say who they are and what they're doing, give a little spiel for a couple of minutes, and then we're going to start this. And we decided, which it's such a sophisticated audience, we're going to really try to keep it up here. We're going to assume you know a lot of the stuff. We're not going to tell you what Alzheimer's is. We're not going to tell you there are 5 million people, all that. And then we're going to try to talk about where we were, where we're going, and maybe some of the disruptive technologies, the ways we're thinking about it now that are differently, and the new opportunities that we have, because there's such an unusual connection now and mixing of all different types of industries. In the old days, it was just you were a biologist and you went up that track, but now there's biotech and there's genetics and there's the Human Genomic Project, and there's the precision medicine, and you have this amalgam of industry and bioscience and ethics. So that I think is fascinating. We have a lot of the players in this room right now, so I want to quickly get to our first. Dr. Rauch, what is your name and what do you really do?
My name just got changed, Dr. Chiocca.
Oh, sorry, I was starting at this way. We can start here, Dr. Chiocca.
And so first of all, thank you very much, Jonathan, and thank you for being here. I am the chief of neurosurgery at the Brigham and Women's Hospital, and as a neurosurgeon, I deal with the interventions, surgeries with patients with brain disorders, particularly brain tumors. Thank you.
Brain tumors.
I'm Merit Sikovich. I'm chief of neurology at Mass General Hospital. I usually try to avoid disruption in that department. But clinically, I see patients with ALS, and I lead a research group to try to find new treatments for ALS and help other people with new therapies for neurology, which is really one of the most exciting things in our field, that we're really at the cusp where we can be talking about therapies for these really serious illnesses.
And Dr. Roush.
My name is Scott Roush, and I'm the president and psychiatrist in chief at McLean Hospital, and also the chair of psychiatry at Partners. In terms of my background, I did a little bit of an unusual thing, which is that after I got trained in psychiatry, I did a radiology fellowship, and so I spent many years at the Mass General doing principally neuroimaging research.
Trying to find out where the superego is.
Exactly, right? and seeing patients principally with anxiety disorders before I moved over to McLean, where they have me chained to a desk. Great.
Merit, well, let's start with you, because the mayor mentioned his mom had Alzheimer's. So I've done nearly 700 segments now for CBS over the last 9 years, and a lot of them have been around neurological subjects. Certainly Alzheimer's is one of the top ones that we do. And I have to say, it's a tough one. We end up doing a lot of pieces where we have poignant segments about families that are affected. And there have been a lot of studies that have been kind of disappointing in this field. And I feel that I take great pains to very carefully describe these studies, exactly where they are. This is phase 1, this is phase 2, these were mice, because I feel that it is a real responsibility on my shoulders to not give false hope, to put things in the right perspective. So with that as a depressing background, what should we be excited about? And what are the changing paradigms for when you say even 10 years ago to now when we're thinking about earlier diagnosis and perhaps using genetic screening and maybe even thinking out of the box?
Yeah, huge changes in Alzheimer's and other neurodegenerative diseases. You know, during my training, basically it was all about taking a history and trying to figure out if they might have Alzheimer's disease. We didn't have any tests or any way to really know, and it would unfortunately be at autopsy whether you know whether it was Alzheimer's or some other disease, and no treatments. Now, you know, we can diagnose earlier, for sure. We're really trying to diagnose earlier. There are, you know, imaging approaches, PET scans, MRI, CSF studies, so we're much better at the clarity of the diagnosis. There's a few treatments. They don't do a lot, but it's like the first crack, the cholinesterase inhibitors or memantine. But where the field is really going and the excitement is on some of the newer treatments to try to get rid of A-beta, some of the new models. We heard about Rudy Tanzi's recent award. It's really about building a 3D model of Alzheimer's disease to screen drugs. I think and I hope the field will get where we can help patients today with Alzheimer's, but also try to prevent it. You know, are there things that we can do brain health-wise to prevent it? Can we screen people in their 50s like you get a colonoscopy in your 50s? And if you're at high risk, start some interventions. You know, whether that's 5 years away, 10 years or more, I don't think we know, but there's a lot of hope there.
What are some of the ethical issues there, right? So I know now the new paradigm is that we're finding it the reason why a lot of these drugs aren't working is we're just using them too late. It's like giving somebody Lipitor after their fifth heart attack, they're already in heart failure, and it's too late. So we say the changes that occur in the brain may start 10, 20, 30 years before the mental decline. So what does that mean in terms of screening? When I have my patients, actually this has come up in my practice where somebody was worried about it. First of all, they're worried about getting screened because then they lose their ability to get long-term insurance if they are positive, although GINA prevents discrimination. Still, it doesn't prevent that. They're worried about what kind of treatment is available for them, and a lot of them just don't want to know. So how do you put that into the paradigm of trying to get people earlier to get them in these trials? Because it sounds like you really need them 20 years earlier, right?
I think it's going to be information. We definitely have to get the insurance issue off the table for Alzheimer's as well as other issues. But it's about information about, given X test, what's the percent that you might get a disease, and then what's the chance if we intervene now that might make a difference. And not everyone will want to be screened, just like not everyone wants to be screened for genes for breast cancer or other things. But some people will, and especially if we have meaningful treatments that can even delay the onset of something like Alzheimer's a couple years. That could be huge for the patient, their family, and our economy.
I want to move on to Scott, but I have to ask you one other question, which is, we're talking about Alzheimer's. For people in the audience who are looking to develop drugs, devices, what is, just fantasize. You're on the Starship Enterprise, and it's it's the future, and it's we're thinking about tau, amyloid. What about microglia now? What about the microenvironment? What about inflammation in the brain? Are there things that are tickling your imagination now that you're thinking, oh, we are going to be so surprised it's going to turn out to be a whole different paradigm? Is it just for people out there wondering about where they should be going?
Sure. I think in all of neurodegeneration, now people are thinking that the immune system might be a big player in how the disease spreads, and that we could actually make a difference, huge difference for people today if we could find a way to get those drugs into the brain and dampen down that inflammation, and then maybe we can turn these into a much slower disease. The other fantasy is really on the gene therapy. Can we, at least for the people where we know the cause and the gene defect, can we intervene early and prevent it again from happening?
Scott, you're nodding your head, so what are you thinking about this?
Well, I'm really considering, in a way, picking up on a point that Merritt made about early detection, because I think we're really in a place, especially in psychiatry, where that's critically important. You know, by and large, our psychiatric diseases, much more so than even neurology and neurosurgery, are diseases that emerge in youth. Many of them really neurodevelopmental disorders. So, you know, if you think of the prevalence of psychiatric illness as being over 1 in 3 people lifelong, over 50% of those people have onset of their psychiatric illness before age 14 and 75% before age 24. Currently, and I think it's really clearly exacerbated by stigma, it's really the rule much more than the exception that people are suffering with psychiatric illness for years and sometimes decades before the conditions are detected. which is partly why, more often than not, really from a healthcare delivery standpoint, we're often learning of psychiatric illness in an individual when they're presenting to an emergency room or when they need hospitalization, as opposed to being able to intervene much earlier. Really just as Merritt was saying with neurodegenerative disorders like Alzheimer's disease, it's potentially even more important in these neurodevelopmental disorders like psychiatric illness.
You can't skate over that issue of stigma. I interviewed a kid after one of the shootings. He had schizophrenia, and I said, do you feel there's stigma? He said, sure, there's stigma. Every time there's a shooting and they see me, they think, every time there's a shooting by a crazy person, they think, I could be one of those, I could be the crazy person. So do you see any movement in our society towards doing something about that? Because without that, the early diagnosis doesn't happen and the early treatment doesn't happen.
I do. It's a great point. First let me just say the whole issue of linking violence with psychiatric illness is very much a double-edged sword. On the one hand, people are drawn to it because by highlighting violence and its potential link to psychiatric illness, people see that as an opportunity to leverage resources and potentially even legislation. When in fact, by and large, people with psychiatric illness are on average no more likely to commit violent
Unless they're on
crimes
drugs or alcohol.
than others. But more generally, I think what we can say, as I like to say, my parents' generation, or certainly my grandparents' generation, there was a stigma that I think we're all aware of in cancer care. And now we see how far we've come in a matter of 1 or 2 generations. And I think there's really tremendous hope in psychiatry that similarly, we're beginning to see the erosion of stigma. We're beginning to see prominent people, celebrities and others stepping forward and speaking openly about their psychiatric illness. Certainly, psychoeducation is something that's public education is really a critical part of what we do throughout the partner system. And I think beyond stigma sort of as a societal reality, we're making huge progress with regard to legislation, and Partners has been a leader in that regard as well. As we move to parity legislation, which makes a huge difference in some ways, brings us full circle to the other matter you raised about insurance payment, reimbursement, and whatnot. So I think we've come a long way. There's great reason for hope, and in some ways bringing us back to the theme of the meeting here over these few days. I think the medicalization of psychiatric illness, the real recognition that for the most part these are brain diseases, goes a very long way, both in providing patients and their families models to think about their illness, no different in some ways from a neurologic illness or certainly even diabetes, but also I think for the public at large to really think in a disease model.
So that actually, you got to what was going to be my next question, which is what are you thinking now that you didn't think 10 years ago? And certainly thinking about, nobody would ever tell somebody to snap out of their diabetes or snap out of their asthma. But they do tell people to snap out of their drug addiction or snap out of their psychiatric illness. Is there something that you're doing now that you couldn't have imagined that you were doing 10 years ago, aside from in the realm of sports?
Well, I think, again, within the field, I think the disease model is long-standing. It's a matter of really getting it out there into the public and, frankly, even into other specialties of medicine. The stigma also sort of within our field to some extent, not just out there. But as I'm sure we'll get to speak to more over these next 40 minutes in the next few days, really some of the greatest advances in psychiatry and psychiatric care, there's great opportunity on the high-tech side. But much of what we're doing today that's really revolutionizing care really has to do with service delivery models. And for instance, screening in primary care and delivering more of the care right in primary care and patient-centered medical homes. And so I think that's a major theme you'll hear, again, not only during these days, but also for years to come.
But that's less sexy to people, right? I mean, you want to see, there's Fleming, and oh my gosh, those streptococci, boy, that green stuff, penicillin.
Yeah.
Is there some sort of transformational model difference that could happen now that would make you treat patients differently 5, 10 years from now than, I mean, does it have to do with genetic screening? Does it have to do with hooking up genotype and phenotype and obviously clinical testing?
Well, there's no question that the tremendous advances in translational neuroscience hold as much promise in psychiatry as any other subdiscipline in the clinical neurosciences. But I think if you're really asking in the last few years to what degree have we delivered on the promise of translation, there are some very good examples, but they are few. and in some ways in linking the members of this panel together, and maybe my own bias as someone who comes from a background of neuroimaging, the advances we've made in understanding the neurocircuitry of disease and the ways in which that can be leveraged through neuromodulatory treatments, which are shared to some extent with different targets across these subdisciplines. That's an area that I think is alive and well today. Looking forward, there's no question, genetics and molecular biology holds much of the promise going forward.
Antonio, what were you doing 10 years ago that you couldn't imagine today doing?
I think 10 years
The other way around. What are you doing today that you couldn't imagine 10 years ago?
Well, I think that, for what we do, which is brain surgery, I think the two advances that are occurring and that continue to occur are precision, right? 10 years ago, even 15 years ago, we used to do very large operations, very large surgeries, because we actually really did not know where to localize the lesion, and there was a lot of guesswork. I should not say that. But that is getting less and less. We now have very precise technologies, some based on imaging, some based on functionality, finding functional areas of the brain. So we would know more precisely where to go, what to stimulate, what to take out. One of the examples is epilepsy, finding epileptic foci in the brain and removing those. That's been shown now in phase 3 clinical trials to actually be better than drugs. Gets people off the anti-epileptics. And the second thing is miniaturization. We're having smaller and smaller instruments. We're getting more microscopic, and I see the future going into where we're getting into more miniaturized areas so that we can eliminate any collateral damage to normal brain structures and just do what we're supposed to do.
How does that extend into measuring electrical activity inside the brain? There was this interesting report last week from the University of Iowa in collaboration with London. A guy came in, it was a case report, he came in to get his epileptic focus. You might have seen that mapped, and so they had his skull, half his skull off on the left side. He happened to have tinnitus. So it gave them this opportunity to study where the tinnitus focus was. And they figured it's going to be in the auditory cortex right here, no problem. It wasn't. It was all over the place, in the areas for attention and memory, and emotion. So somebody was telling me at lunch, there's a gel, maybe you can maybe deliver something to the surface of the brain that's not as invasive. Where are we with that? Because I think gathering data is something that we're sort of poised to do. What we do with that data, whether it's the Human Genome Project or whether it's electrical activity, is a whole other thing. But are we able to get that kind of information better now?
Well, I think you're pointing to a very important fact, which is the fact that we can come up with great drugs, we can come up with great things to do to the brain, but you need to get them to the brain. And so one potential possibility, for example, is gels. They're impregnated with particular drugs that you could apply, even in fairly non-invasive. There's always going to be a little invasion because we have to get them in there. Or ways in which you can get drugs or molecules, antibodies across the so-called blood-brain barrier with various techniques and technologies. One of them, for example, is focused ultrasound.
I heard at lunch, you can poke a hole in the blood-brain barrier, that kind of
with
surprised me.
just an ultrasound machine, basically. And so I think that that is the future. That is the future of delivery. That's the future of how we can get the appropriate concentrations of a drug or a molecule to the appropriate spot in the brain. And that's the challenge. We're not there yet, but we will be.
So we have this think tank here, and we have the think tank in the audience, and you have people from industry, from every walk of life here. It's impossible. I'm putting you on the spot to say think out of the box, but think out of the box. If you're them and they're trying to figure out what's the next product, and you're thinking about all the different resources you have, you've got Francis Collins came by to CBS a couple of weeks ago. He said they're going to be enlisting 1 million people and sequencing their entire genome at a cost of $1,000 bucks. That's $1 billion. They're going to be following them. They're going to be able to run he wants to do these big studies where basically instead of taking 3 years to recruit people, you have an idea, you send out a ping to 1 million people who wants to sign up, bang, you sign up. You know about the whole brain initiative that he's doing. You know that industries of all kinds are involved. What are the collaborations that you need, that you want them to provide what are the services that you would love to have? What's your wish list to do the kind of research that you think could bring you into the next phase? Merritt?
Yeah, so one thing is the analytics on all this data. So you know, an example from the world I'm in ALS, we have all the centers using Epic, this electronic medical record system, agreeing to use the same ALS forms for every patient seen in this country. So we can get that data. There's agreement on how to share it. We can merge it with you know, the genotype data, but that's a lot of data. Or we can have Fitbits, but how to use that and how to pick out from there, are there different subsets of patients? Are there different targets? I think we could use the help on that end.
To roll it all up.
Yeah.
And I know Google and Microsoft and Apple, they're all working about it. They all have the devices and the bracelets and the everything. How do you standardize that? And Epic, which since you mentioned that, doesn't really handshake with every other Epic, as I'm finding out as I'm trying to refer somebody to Hopkins, they also have Epic, and we're not sure exactly, you know, how to get that information down there, even though they're both Epic. So it's an Epic challenge. Scott, what do you need? What do you need? They're waiting to serve you.
Yeah, well, not every challenge we face is a numbers game, but I would say one place where it's pretty crystal clear that it is genetics, and in particular the complex genetics of psychiatry. And I think this is a relatively recent insight, you know, forged by again some of the people in this very region and these institutions. That you know, if you looked at the history of some of the discoveries in neuroscience genetically, simple Mendelian genetics suggested that you could solve these problems with modest collections. Now, understanding the complex genetics of often genes, not so much of major effect, but many genes, many genes, each contributing in more modest ways, it's crystal clear that the collections need to be just mammoth in their scale. And so, you know, it's really been a study in the way that consortia come together to enable those large collections. And as recently as just in the last year or two, some of the products of those collections have yielded not only leads with regard to schizophrenia and psychotic disorders, but also the identification of some potential risk genes that cut across diagnoses. And that too is kind of a burgeoning theme within psychiatry, that we know with the advent of this most recent DSM, that as much as we would wish to have syndromic diagnoses that map nicely onto pathophysiology and disease, currently the way we name our diseases probably don't match well with the underlying neurobiology. But really, genetics, psychiatric genetics, is one of the places that's a very good match for for sort of the thought experiment or dream scenario that you mentioned, where it really is a numbers game. A lot of the other places where we have advances yet to go, it's not so much the numbers game as other cleverness and just moving the ball forward with resources.
So Risa Sperling, because you don't have to be smart, you just have to know somebody smart. Risa Sperling said maybe you shouldn't collect 1 million people, you do 500,000 people and get the phenotypes on everybody so that you can really match those all up. For the three of you, is there some analogy to be made by what's happened in the field of oncology? I mean, really, when you look at oncology, when you look at all the stories we cover, heart disease deaths are going down, cancer deaths go down, and in the neurocognitive fields, it's sort of not so great. There is a paradigm shift that we all know, where in the old days, meaning when we all went to medical school, there was colon cancer, there was lung cancer, there was breast cancer. And now we say, wait a second, maybe we should look at the molecular pathways that go wrong, the genetic mutations, because they may be shared. And maybe if we identify them, you can start treating orphan diseases where we didn't even realize because there wasn't enough money and interest but say, oh, look, that's a KRAS defect too. Let's do that. Is that where we're headed in the neurocognitive field?
I hope so. And I think that, you asked how we can interact with the technology. Yeah. And there's so many technologies out there. There's so many tests. We're talking about biomarkers. We talk about genetics. And I hope that that interaction would be to understand that as you implement clinical trials, you find out new information. And you may find out actually that the things that you thought was going to work for one set of patients with a certain genetic background actually works for somebody else, for another group. And really to understand that and to not give up on something and to really work together to try to devise the next clinical trial that will be better than the previous one.
Are we going to look back and say, I can't believe we did that ALS, Parkinson's,
Yeah.
when it was like this? And are there models in order to look at that, three-dimensional gels with neurons that you can actually work out of the body and test things on, and things will light up or not light up? Where are we with that?
I think we're learning clinically that a lot of these neurodegenerative diseases overlap. Again, in ALS and frontal temporal dementia, before we thought they were separate diseases. Now we find that half the patients with ALS have frontal temporal dementia. We're seeing overlaps with Alzheimer's and ALS and Parkinson's and cognition. But I think the models so far in the lab are really still kind of single disease focused, and they're just starting to think about what you mentioned about how do you get them to cross a little bit.
Well, 5 years ago, we did this big Where America Stands at CBS News on Alzheimer's. And I remember Dennis Selko saying, if men were mice, we would have cured Alzheimer's already. We were just,
He said that of every disease.
He says that about every, right? So in the last minutes of this talk, so that we don't end, I want to end on an up note. We're understanding theoretically where we might be headed. But give me, each one of you, a specific example of something that you're doing now on a specific disease or a specific problem or a syndrome that you really couldn't have been doing 10 years ago or 15 years ago or whatever. And if you can't come up with it, that's okay too. It could be that it's still off in the future a little bit. But I want to have a little bit of a reality testing as we sit here thinking about how great we are. It sounds to me, as the reporter, that we've got this incredible tool set right now. I mean, we've never had a tool set like this ever. But that we haven't built the stuff yet where I can actually go on CBS News and say, look, everybody, we have a really promising treatment for whatever. Is that fair?
I think it is. I think what we're learning is more than any technology, more than any imaging, more than any functional, is what we're learning more and more is really combining the outcome of patients, understanding which patients will do well with a certain treatment versus those that do not. You talked about bucket lists. You had a brain tumor, you had prostate cancer, you had ALS. I think more and more we're learning, look, you may have ALS, but the genetics and the phenotype from the genetics really tell us is that really that's the type of ALS you have, and maybe that's the treatment we should have. So we're learning more and more to link the outcomes to the treatment, to the genotype of the patient.
What do you tell? Good. No. What are you telling those patients now? Because we've done the pieces where we've done a couple of pieces on stem cell treatment for multiple sclerosis, early phase. We've done one for ALS, early phase. We have no idea how it's going to turn out. Somebody comes to you, they have ALS. What's your spiel? What do you say to them?
Well, luckily, I don't see patients with ALS. I see patients with glioblastoma, which is even worse.
I think glio is, and there was that great 60, of course I'm CBS News, but there was that provocative 60 Minutes piece with about using poliovirus to treat, again, phase one. I thought it was very brave to include the death in phase one, to show people, to teach people that that's what phase one is about. It's to try to get the right dose. So I like that part of it. But again, people after that said, oh, there's this great breakthrough, but it's phase one, but it's this new kind of concept that the polio isn't killing the tumor, it's sort of stripping the tumors have cloaking devices, and so you're stripping the cloaking device off, to go back to the Star Trek analogy, and then that allows your immune system to suddenly say, oh, there it is, it's been hiding. Yeah. So it's not the polio that's getting the last cancer cell, presumably it would be your own immune system. So is that something?
So one of the things about glioblastoma is that it tries to evade the immune system. It tells the immune system, don't attack me. I'm one of you. I'm part of your body.
Right.
And so things like poliovirus or other viruses or other immunotherapies are all to say to the immune system, it's not true. It's a lie. This is the enemy. Come and attack us. I think the trick in phase one trials is that they showed 2 patients in that 60-minute segment that did really well, and then others did not.
And then one woman died.
And the question is, why did those 2 patients do well? Can we go back and figure out, what was about those two patients that really helped them, respond well to the poliovirus? And from there, design the next clinical trial that targets patients like that.
So pulling back now to the million people who are out there and we know their genomes, or maybe every American, or in Iceland, maybe every person in Iceland, as we know the Decode project is trying to do, I guess. Is that some way of looking at the outliers, like just in the same way that we find out about cholesterol treatment because somebody has a natural knockout of both genes? Is that going to teach us something about the treatment of these, because we have so many people, we're not recruiting them, we're finding them, these huge...
I think so. We will have all this data, all this genomic data, and we'll be able to link it with the phenotype of the patients, their outcomes, their response to treatment. And having all this as the background will help us devise the next set of therapies for that particular disease based on your genetics. And this is going to be the best outcome for you based on your genetics.
And we see that happening already in a lot of childhood genetic diseases like Duchenne muscular dystrophy, or SMA, where there are really gene modification approaches specific to a particular mutation type. So it might just be a small number of the patients, but it's starting to really make a big difference. And that's one of the most exciting area, I think, in neurology is what's going on in SMA and Duchenne and some of the genetic disorders. They can really actually already go into patients in phase 1, phase 2. SMA, they're in the phase 3 with the antisense oligonucleotide approach.
Do you have, and I would say this to all three of you, do you have wish lists for the next holiday season, whatever? What do you want? What do you need? They're sitting out there. What do you want?
So, I hate to keep bringing it back away from space-age neuroscience because I think ultimately space-age neuroscience... It could be a better pen. I mean, it could be whatever is practical. Space-age neuroscience is ultimately the future for the field. But today, the reality is we have treatments that work relatively well that people can't get in the United States or globally.
That's fair.
And so, for example, one of the things we're doing in an innovative fashion is delivering evidence-based cognitive behavior therapies through the internet in a way that will functionally build our capacity against the reality, the fiscal reality of the nation, and potentially reach, up to 25–30% of people with depression if they're screened in their primary care office. In Australia, they hand those people a link, and ultimately they get the ICBT they need. It's equi-efficacious, in some instances actually preferred by patients to having to schedule an hour and go see their psychologist across town. So I think these cost-efficient capacity-building efforts that really deliver care to patients are very important in the here and now. Meanwhile, I think to the points that have already been made, I mean, it's never... you asked us to be optimistic. Oh, my gosh. Someone who understands this field right now, how could they help but be both optimistic and excited about, the science fiction of yesterday being the reality of today, whether it's, induced pluripotential stem cells or optogenetics or all the fabulous tools we have to move the field forward. But I know, at least in psychiatry, and I think it's true to some degree in neurology and neurosurgery as well, we wish we were already there. We wish we could make the list of things we've already delivered on all the way through regulatory approval. And I think all of us have gotten a little tired of saying 10 years, 10 years. But I think now it feels more like 10 years, where 20 years ago when we were saying 10 years, we should have known it was 30.
Are we thinking correctly, or do we need to move a little bit about how we even think about these trials and the statistics of how many people we need? And with all these devices and social media, even doing follow-up. So people who are on neurocognitive treatments, is there a way of just following the way they order things online? Again, Risa Sperling was talking to me about, maybe you could say, how quickly do they do an Amazon payment? And that could somehow, wouldn't that be more real, actually, than go ahead and do this following test? Come into my office where your pulse is going to be 30% higher than normal and you're going to get the adrenaline flowing. Are there ways of using these devices to measure just the way we live our lives, and then maybe that will help us to learn things that we don't realize?
Absolutely. I think in lots of diseases, Parkinson's one example, they're already doing a lot of their visits for clinical trials through Skype or televisit. They're seeing the patients at home. They're giving them devices to wear. I mean, I think in the big picture, if we have a drug that works, we're going to be able to see it that way, but also our traditional way. I'm not sure that the way we're capturing data is necessarily the reason we haven't seen such big successes, but I think it would make it a lot easier for patients in a way that involve a lot more patients if we lowered the burden to be part of the trials.
Have you had any dealings with, patients like me and other databases where people are actually putting their own, patients like me, they were running their own trial at one point, right? So is that useful? Is it distracting?
There are some patients that are very interested in cleaning their own data, and some of them put it online. They get a lot of information back from other patients, from other physicians. I think that's all welcome. I think that is really some of the way of the future, where you globalize the ability to get as much information as possible to improve the care, making sure that you're not making it worse, actually, because there's so much information, it paralyzes your decision making. But just going back to what you were saying before, I think it's very important that that we think about this as we stratify patients down to smaller and smaller groups, right? We're not going to have the statistical power that we currently use in our clinical trials. And so we're going to have to come up with better statistics or better ways of looking at the, we know that these 3 patients that have this particular mutation or this particular genetic problem respond well to this drug, and there may be 3 patients in 3 different cities in the United States, or there may be this globalization of where we're using patients from multiple countries to really come up with enough of a statistical power to make a meaningful outcome analysis.
So what are the unintended? We have 3 minutes left. How many people in the audience asked for their iPhone or BlackBerry? They wrote to somebody 10, 20 years ago and said, why don't you invent this? Right? This sort of just came, and now every day I have 400 emails that I have to delete. What are are there any, just as important as the fabulousness that's coming down the pike, are there unintended consequences to all of what's coming down the pike that you think about? Whether it's the genetic databases, Google, Microsoft, Apple having data and metadata, and institutions, overlaps, business, government. What's on your mind?
Well, I think privacy concerns are always paramount, number one. Number two, I do think that having so much information sometimes can really paralyze me as a doctor sometimes, trying to make the right decision, trying to figure out what's important and what's not. What are the critical pieces that are going to help me go to the next decision step, and what is just the noise. And so, that's another area of technology advance. How do we come up with the informatics that help us decide, as patients or as physicians or as society, what is the important data that's going to link you to the next decision process?
Do you see us having that right now?
I don't think we have it right now. Absolutely not. I do think that that is something that should be worked upon. Definitely.
I think the social media can be used to really help patients by giving them good information and to letting them know about clinical trials and research. It can also mislead and give anxiety for patients that they don't know what to do because there's so much information coming out. So I think there's a role for physicians on how to teach and use that to get good information to patients.
And Scott, it is the number one problem, fear in my patients. It really is, of everything, is I have Alzheimer's. The worried well, is it a senior moment or is it Alzheimer's? Can you help that person? And we kind of tongue-in-cheek say, well, if you can't find your car keys, it's one thing. If you find your car keys, you don't know what they do, it's another thing. And I think that's kind of, it's too pushing it off. People have real fears and real concerns, and it's terrifying.
Sure, absolutely.
Does some of the new technologies help us with that?
Let me first just say that, anxiety disorders, when people use the term the worried well, are among the most paralyzing disorders that we have among humans. As I see us count down the last 40 seconds.
No, you can say a ton. You can say a ton.
I actually can't help but pick up on one of your earlier comments, which is, you had joked about disruption previously being sort of a bad thing, and now it's a good thing. And you held up your iPhone, and you talked about unintended consequences. what I would say in the area of behavioral and mental health, the unintended consequences of people carrying around iPhones may really be among our most important source of very dense data about people's behavior, and also a cheap way to interact with people behaviorally in terms of gathering information about symptoms and delivering treatment. So I'd be more than glad to end on that note, that I think our iPhones may end up being one of the most cost-efficient ways to deliver better behavioral and mental health care. And also, the data that are captured passively on an iPhone may give us some of our best leverage to predict who's about to relapse in psychiatry. And so that's another example of something unintended, but maybe for the good.
And that's positive. Yeah, if marketers can figure out what kind of couch I want to buy, they can maybe figure out other information about my life. But and with that, I will couch this entire conversation in optimism, and thanks for everybody for inviting us, and on to the next one.